Hey, welcome everyone. My name is Maura Canavan and I am with the Community Health and Wellness Department at Suburban Hospital. Today we are here to discuss hearing protection with Dr. Deepa Galea. Dr. Galea is a fellowship-trained neurologist and lateral skull-base surgeon. Her clinical practice specializes in the surgical and medical treatment of the middle ear, inner ear, skull base, and facial nerve disorders in children and adults. She will discuss hearing protection and hearing aids, and we will have time for questions at the end. So please feel free to send them in the Q&A box as they arise. After the webinar, you will receive a link to the evaluation, and we would greatly appreciate your honest feedback as it helps us in the planning and execution of our community health improvement programs. This webinar will be recorded and sent out in the coming days to all participants. So thank you all for being here, and I will now pass it to Dr. Galea.
Hi, everyone. I'm really very happy to be able to do this talk for all of you. I'm just going to share my screen so you can see everything here. Okay. Just let me know, Maura, if there are any issues with the screen share.
Nope, we can see it.
Okay, great. So I have no disclosures for today. And as Maura said so nicely, I am an otolaryngologist, so an ear, nose, and throat surgeon. And I did specialized training in otology and neurotology. And so basically, my focus within otolaryngology is on ear diseases and hearing, and cochlear implants and skull-based surgery. That's just my credentials and where I have trained in the past, but I'm board certified in neurotology and otolaryngology and see patients kind of in the entire spectrum of disorders there. And I'll show this information again at the end, but that's my contact information in case you have any questions at the end of this talk that maybe we didn't discuss or that you want to have more information on. And I practice all over Maryland, so in Baltimore, Bethesda, Washington, D.C., and in Columbia, Maryland. And so I just want to start with the difference between an audiologist and an otolaryngologist. And so if any of you have been to an eye doctor or gotten glasses fitted, it's kind of a similar dichotomy. You've got the ophthalmologist, who's the medical doctor who looks at your eyes, make sure everything is healthy, make sure the pressure in your eye is normal, make sure the nerve at the back of your eye is normal. And then you have the optometrist who actually measures your visual acuity, how well you can see, and will fit you to a set of glasses. In hearing, we really have the same dichotomy. So the otolaryngologist is the medical doctor who will make sure that you don't have any diseases of the ear, nose, and throat, make sure the structures of the head are normal, and make sure that any hearing problems are not related to some kind of underlying disorder like an infection or a cancer. Whereas the audiologist is the hearing imbalance scientist who measures your level of hearing and actually helps you with fitting with different types of hearing assistive devices. And that includes hearing aids. It can include things like cochlear implants as well. So we work very, very closely together. Any otolaryngologist that's going to be doing otology or ear-related disorders is also working with an audiologist. And if you have questions about your hearing and you're getting your hearing screened, you will be seen by both of these professionals. So we'll talk very briefly just about how hearing works. So sound waves come through the ear canal, they vibrate the eardrum, and then that ends up vibrating our middle ear bones, which is number 3 right here. When the middle ear bones vibrate, they actually lead to a push and pull in something called the oval window, which moves fluid inside the cochlea, which is our inner ear. That fluid vibrates and it actually stimulates some nerves inside the cochlea. These nerves are called hair cells, which you may have heard of before. And the hair cells convert that mechanical energy of the sound wave into an electrical signal. The electrical signal travels along the nerve to our brain, and then our brain does processing to interpret what that electrical signal actually means. So when there's background noise, our brain can help to sort through the noise to identify the signal that we really, really want. So if you're in a crowded restaurant and a server is talking to you, do you want steak or do you want cake? The brain is using the information that's coming in through your cochlea and helping you identify, is this person saying steak or are they saying cake? But if you have hearing loss, the signal that's coming in is distorted. And so then your brain has to work much harder to interpret that signal that's coming in. So they have to sort out all the noise, and they have a much harder time knowing, did they say steak or did they say cake? And so when you have disorders of hearing, it's not just the ear that is the initial problem. We also have to think about how the brain processes sound. And the brain and the ear are working very closely together. And so if you have a hearing disorder, again, it's not just in the ear that we have to really think about improving your hearing. It's also thinking about how does your brain process sound when there's background noise, when you're competing with other types of sound, when there are people with multiple voices who are talking to you, and how does the brain sort through this distorted signal that's not as high quality as it was before? So we'll get into that a little bit more later. And this is just an animation that shows the same thing. So mechanical sound is coming in, vibrating the drum, causing vibration of your middle ear bones, which causes fluid to shift inside the cochlea, and that'll convert into an electrical signal to go to the brain. So let's talk about the risk factors for hearing loss. When I have patients come in, I tell them hearing loss is usually a combination of 3 different things. So it's a combination of your genetics, your environmental exposures, and your age. And so all 3 of these things work together to produce hearing loss. So if you've had a lot of noise exposure throughout your life, or you've been exposed to ototoxic medications like certain antibiotics or certain chemotherapy drugs, or if you're a smoker, those are environmental exposures. If you have a family history of age-related hearing loss, you might have an earlier onset of hearing loss than someone else who does not have that family history. And then we do know some people who have medical conditions like heart disease, hypertension, diabetes are at a slightly higher risk of developing hearing loss because of lack of blood flow to the inner ear. And there are many signs of hearing loss, and we'll talk more about this too. Hearing loss tends to be quite an insidious thing. But some of the signs of early onset hearing loss are if you have trouble understanding people, you're turning their TV up, turning the radio up. If you can't hear high-pitched sounds, so your high pitches are the first things to go. If you feel like you need to ask people to repeat themselves, if you are having some trouble understanding people on the telephone, if you're having any tinnitus is usually a sign of hearing loss and usually secondary to hearing loss. If people tell you you're speaking loudly, and then especially, and this is really the first thing that people notice, is that they're having trouble hearing people in noisy environments. So if you're in a quiet room, you can hear just fine, but if there is a lot of background noise, you have much more difficulty hearing people than you may have in the past. That would be a telltale sign of hearing loss. Hearing loss is incredibly common. So we think about 38.2 million Americans have some degree of hearing loss. It tends to be not as common in the first 4 decades of your life, but in your 50s, about 1 in 10 people have some hearing loss. In the 60s, about 1 in 4 people. In your 70s, about half of people have some hearing loss that is causing a functional impairment. And in your 80s, we think it's about 80% of octogenarians have significant hearing loss. Tends to be a little bit more prevalent in men than in women. That might be related to noise exposures over time. But it is still a very, very high percentage of people as you get older that have hearing loss. And we are predicting that the prevalence of hearing loss is really going to increase over the next 40 years, partially because of increased noise exposures that are in our environments today. We do know that people who have hearing loss often don't recognize it right away. And once they do recognize it, they often wait 8 to 10 years after their initial diagnosis to do something about it. which is unfortunately enough time for related comorbidities to come into play. So hearing loss is associated with several other comorbidities. And the big one we'll talk about is dementia. But hearing loss, we know, is connected to cardiovascular disease. Tinnitus is usually a sign of hearing loss, can be connected to hypertension, smoking. A big thing is that hearing loss can lead to social isolation. And that can be a very insidious thing where if you're having trouble hearing people in noisy environments, crowded environments, you might start to avoid those environments. And avoiding those environments might lead you to more isolation. And so we think that some of that social isolation, withdrawing, can actually lead to dementia. We've had a number of studies at this point connecting hearing loss to dementia. Even when they control for all of the other comorbidities, we still find that patients with hearing loss have much higher prevalence of dementia. So this has been measured by the Johns Hopkins School of Public Health, which really is the place where a lot of this research has happened. So patients with mild hearing loss are twice as likely to develop dementia. If you have moderate hearing loss, you're 3 times as likely. And if you have severe hearing loss, you're 5 times as likely to develop dementia. There are some new studies that have come out in the last couple of years that are really encouraging, though, because we found that getting hearing aids is actually protective against dementia. So if you're diagnosed with hearing loss, you can prevent the onset of dementia by hearing aid adoption, and hearing aid adoption pretty early. And that's really what has led to this big push to try to get better hearing aid coverage from insurance companies and from Medicare, because we found that hearing loss is so highly connected to these big comorbidities. The next few slides are really more aimed at insurance companies to show the cost of hearing loss to the healthcare system, which is fairly substantial, and the fact that there's higher healthcare utilization in patients with hearing loss compared to their age-matched controls that do not have hearing loss. So they're in the hospital longer, they have a higher rate of hospitalization, higher rate of readmission, and higher rate of having to go to the emergency room. And several studies also from the Johns Hopkins School of Public Health have come out looking at the possible savings to Medicare for coverage of hearing aids. So hearing aids, as you know, can be very expensive, but they have calculated that ultimately you could have significant savings over time because of the reduction in healthcare utilization. So this is just a short video that I wanted to share, and I think it does a better job than I do about explaining what happens to hearing as you get older. So I'm going to just play this.
This series of videos on Hearing and Aging 101 will explain how hearing works and what happens to our hearing as we get older. In the last video, we talked about how hearing works. So, what happens to hearing as we get older? Over a lifetime, our genetic makeup, noise exposures, and aging can all affect the inner ear and lead to a gradual loss of the cells that are located here. This process results in the machinery of the inner ear that encodes sound being damaged and leads to age-related hearing loss. This wear and tear on the inner ear means that the damaged ear can no longer accurately convert complex sounds into a clear signal for the brain. For the brain, the signals that are received often sound garbled or as if the speaker is mumbling. In situations such as quiet rooms where the incoming sounds are still clear, the effects of hearing loss won't be too noticeable. Sounds that enter the ear may be inaccurately converted into an electrical signal by the damaged inner ear, but the resulting electrical code that goes to the brain is still clear enough for the brain to understand the sound. In these cases, the brain even uses visual cues from the speaker's lips to help convert the electrical code from the inner ear into meaning. In other situations, the effects of hearing loss will be more noticeable. In noisy rooms, the sound that enters the ear is already distorted by the other sounds in the room. And this is made even worse as the damaged inner ear now poorly converts this garbled sound into an electrical code that is sent to the brain. In these situations, the brain can't always interpret the signal, and words can often be misunderstood. This type of age-related hearing loss is incredibly common in older adults. 1 in 4 of all adults in their 60s, half in their 70s, and 8 in 10 over 80 have a hearing loss that interferes with their everyday activities, like talking with friends or watching TV. Importantly, scientific research is now showing us the impact that hearing loss can have on our brain and our health, as our brain has to constantly work harder to try to convert sound into meaning. And hearing loss gradually isolates us and makes it harder to interact with the people and world around us. At the Cochlear Center for Hearing and Public Health, we are committed to understanding the impact of hearing loss on public health, and to then develop and test the solutions needed to address hearing loss to improve the lives of older adults. Learn more.
All right, thanks everyone. So let's talk a little bit about noise exposure and hearing loss. I think people often have questions about this. So sound is measured on a scale called a decibel system. And a decibel system is a logarithmic scale. So 10 decibels is 10 times louder than 1 decibel. 20 decibels is 100 times louder. So a 10 decibel increase in sound actually means that the loudness of that thing is 10 times more. And a 20 decibel increase in sound means the loudness of that thing is 100 times more. So 100 times more energy is hitting your ear. And we can tolerate high energy sound for short periods of time, but the longer you're exposed to loud noises, the more damage it can do to your hearing. So a washing machine is about 70 decibels. Heavy traffic is about 80 decibels. We can usually sustain that for quite some time without damaging our hearing. When you get to 90 decibels, about the sound of a leaf blower, we really only have about 2 hours exposed to this sound before we have hearing loss. If you have a very loud sporting event, it's about 100 decibels, that's 14 minutes. A concert, it's 110 decibels, really only 2 minutes before you have hearing loss. And if you're right next to an alarm siren, that's 120 decibels, you really only have 1 minute. So even my youngest patients, I tell all of them to have hearing earplugs when they're going to large events, because often things are much louder than you realize that they are. There are even restaurants that are sitting at basically 95 decibels most of the time. There is a push to try to get earplugs for the workers who have to be in that environment for 8 hours or longer. But just be mindful, this is about the scale that we're looking at when it comes to hearing protection. And then this is again just another graphic to tell you that the energy really increases exponentially as you go up in the amount of decibel sound. And so government research says safe exposure is 85 decibels for 8 hours a day. And if you're exposed to a higher decibel range for any longer period of time, you're at risk of causing hearing loss. So painful, where it's so loud it's painful, is about 120 decibels. At 100 decibels, it's going to feel like it's very loud, very noisy. 60 decibels is mostly what you have in a moderate to quiet room. If you are sitting in a room that you think is dead quiet, there's nothing there, that's still probably about 20 to 30 decibels in terms of the background noise that is present in that room. Hearing loss is in 4 different stages. So we have normal hearing, mild hearing loss, moderate hearing loss, severe hearing loss, and profound hearing loss. So in normal hearing, you should be able to hear things like the water running, the fridge humming, birds, and a lot of female voices tend to be in this normal hearing range. And then just to help you, when you get a hearing test, it's going to be on a graph that looks like this. On the left-hand side of the graph is the low frequencies, and the right-hand side is the high frequencies. At the top of the graph is the lowest decibels, and the bottom of the graph is the highest decibels. So we'll go through some examples here. So as you start to develop some high frequency hearing loss, people will say that they struggle to hear women's and children's voices first because those voices tend to be in the high frequencies. We have difficulty hearing words with S, H, F, and TH sounds because they have a slightly softer sound to the consonant. You might no longer hear birds chirping. And then when people talk, you might feel like you can hear them, but you can't understand them. And those are really common symptoms of high frequency hearing loss. Hearing loss is really insidious. Most people don't know they're experiencing it until it's very severe. And your brain will take a much longer time to adapt to things like hearing aids. So the human brain adapts very quickly to hearing loss. It's tuning out sounds, you're avoiding situations. But we find that the worse that your hearing is, if you try to use hearing aids at that point, the brain has to do quite a lot more work in order to reinterpret what that sound is. It's important to check your hearing regularly, unfortunately, because most people don't know that they need hearing assistance until it's quite severe. And the human brain is remarkably adept at adjusting to progressive hearing loss. So as hearing ability and sound input go down over time, the brain pathways change. So the brain's interpretation of that sound, the ability of the brain to interpret sound starts to decline quite a bit. And so that means that people are bad at judging their own hearing ability. It's valuable to consider because your level of hearing loss will influence which type of hearing augmentation device is going to work for you. And then I recommend that all of my patients get formally tested at age 65. And if they have a hearing loss, to be tested every 1 to 2 years after that. A lot of workplaces where you're exposed to noise, so especially in the military and in factory work environments, the workers get an annual hearing test as well. So we'll talk a little bit about just getting your hearing tested and thinking a little bit about hearing aids. So even if you're considering an over-the-counter hearing aid, the best place to start is to get a hearing test. You can do that in a private practice or hospital setting. Hearing tests are paid for by most insurance companies, including Medicare, at least once a year. It's much better to get a formal hearing test than using a screening app on your phone, because the screening apps on your phone are helpful, but they're greatly impacted by the quality of your headphones and background noise. A hearing test usually involves an audiologist looking at your ears, blowing air into your eardrum to see how your eardrum actually bounces, making sure it's functioning, and then having you listen to and repeat words and respond when you hear tones at different frequencies. And then after that test, the audiologist can tell you the severity of your hearing loss, if it's mild, moderate, severe, or profound. And based on the severity of your hearing loss, they'll tell you if you're a candidate for hearing aids, or if you need to be referred to a doctor for some follow-up testing. So if they find some abnormality where one ear is worse than the other, or there's fluid in the ear, or you're having a lot of vertigo, those would all be reasons for you to see an otolaryngologist in addition to the audiologist. This is what a hearing test looks like. The blue is the left ear, the red is the right ear. And this is the normal, mild, moderate, severe, and profound are the ranges that we're looking at. So you see this person has high frequency hearing loss. In the highest frequencies, they have severe hearing loss, but in the lowest frequencies, they have normal hearing loss or normal hearing. And so everything at the top of this graph are the frequencies that this person cannot hear. Everything at the bottom of the graph are the frequencies that they can hear. And so if we map it to what we were looking at before, this means that this person might be able to hear a refrigerator humming at the low frequencies, but they probably cannot hear birds outside or leaves rustling. They might have trouble with female voices because those are at the high frequencies. They might even have trouble with children's voices, might have trouble hearing crickets outside, but they can probably hear male voices just fine. They can hear things like a motorcycle or vacuum cleaner or piano just fine. And then all of these things at the high range, an airplane, a lawnmower, they can hear that as well. You'll also notice letters of the alphabet here. So different letters of different consonants have sort of an inherent loudness to them. and an inherent frequency to them. So F, S, TH sounds are pretty high frequency, whereas Z, V, J, M, and G are pretty low frequency sounds. And that's why for some people, they feel like they can hear a person talking, but they can't actually understand what that person is saying. And that's because they're missing out on some of the consonants. They're having to do a lot of guesswork to figure out what the word is that they're hearing. That's where that brain doing the interpretation really comes in. Let's talk a little bit about hearing aid coverage. So please talk to your insurance company to see if you have some hearing aid coverage. It's becoming increasingly common. Many private policies have at least partial coverage for hearing aids. Your insurance company might have some restrictions about where you can go for prescription hearing aids, but I think it's worthwhile to take a look. If you don't have insurance, you can choose if you want to pay out of pocket or get an over-the-counter device. Right now, Medicare does not include hearing aid coverage. It was in a bill a couple of years ago to try to include hearing aid coverage. That did fail. And it is something that comes up in Congress frequently. So if that's something you care about, call your legislators and tell them that you would like hearing aid coverage. We did do a survey of a large number of patients recently. About 53% of them said they had zero insurance coverage for hearing aids. A third of them said that they had partial coverage, and only about 10% said that their insurance plans covered hearing aids fully. And we'll talk a little bit more about prescription hearing aid cost and over-the-counter hearing aid cost. So prescription hearing aid cost varies from about $1,000 to $14,000 for each pair. It's probably closer to about $2,000 to $3,000. Over-the-counter hearing aids can be anywhere from $500 to $600 to $6,000. The average price is about $850. If you've tried hearing aids in the past and you were not happy with the results, please don't automatically judge the devices that are out there today by the ones that you may have tried in the past. There have been significant technological advancements in hearing aid manufacturing, and that is primarily because of electronics companies making advances in headphone design. So all of our AirPods and headphones and earbuds that are getting smaller and smaller and higher quality, a lot of that research that has gone into making those electronics better has also gone into making hearing aids better. The other thing to be aware of that I always tell patients is that your brain's interpretation of sound is also really important. So if you have two patients at age 80 with the same degree of hearing loss, but one of them started wearing hearing aids maybe at age 60 when they first developed the hearing loss, and the other one waited until age 80 to get the hearing aids. The person, even though they have the same level of hearing, the person who started wearing hearing aids at age 60 have much more success with the hearing aids, get much more clarity of sound because their brain never forgot how to interpret sound. Whereas if you wait until you have severe hearing loss and you get hearing aids, often there's much more frustration because the brain has to almost relearn how to interpret the sound that's coming in that it hasn't heard in a very long time. So we get a lot of questions about over-the-counter hearing aids. So we are going to talk a little bit about over-the-counter hearing aids. So over-the-counter hearing aids are for adults who have mild to moderate hearing loss. It's not for people who have severe hearing loss. So children and people with profound hearing loss really should see a medical professional. Everyone has different needs. So there are many types of over-the-counter hearing aids, and you really might have to do a little bit of research to find the type that's best for you. We found that adjustability is very important. So these several over-the-counter hearing aids have situational sound modes. So if you're in a noisy environment, you can turn on one set of programming. If you're listening to a lecture where the lecturer is in front of you, you can turn on another set of programming. If you're in a quiet room talking to someone, it's a different set of programming. So being able to adjust for different situations can be really important. And then the other thing, again, is to give it time. So your brain really needs to adapt to the sound that's coming out of the hearing aids. And so make sure if you get over-the-counter hearing aids that there's a generous return policy so that if you don't acclimate to them well or you're not getting good results, you can at least return them and get your money back. Over-the-counter hearing aids are sold directly by the manufacturer. Again, it's for mild to moderate hearing loss, and it's adjusted by the patient, not by an audiologist. An audiologist is not involved at all in the programming of an over-the-counter hearing aid. And they're available now, again, because we've made technological advancements, there's a ton of demand, and because we've had legislation passed most recently in 2017 that allows for these devices to be sold on the market. Any devices that are being sold as hearing aids have to meet FDA criteria. So they have to meet FDA guidelines. There are some devices called personal sound amplification products. These do not meet the FDA guidelines as hearing aids. Those are usually meant to enhance sound in situations like bird watching, but they're not really meant for people with hearing loss. So they're not hearing aids. They're not approved by the FDA to be called hearing aids. The reason that we were able to pass legislation is to, number one, try to increase competition, bring in some tech companies, so it's not just hearing aid companies, reduce prices, increase access to hearing aids, and then reduce the stigma. The caveats are that candidacy is self-perceived. So if you don't have a hearing test, you don't necessarily know if these are the right device for you. And these are really meant for people with mild to moderate hearing loss. If you have more severe hearing loss, these are not the ideal device. The prices can still be high. So average is about $850, but can go up to $6,000. And then the other thing is to just be aware of how much support you might need for a device like this, because with over-the-counter hearing aids, you don't have anyone to help you with programming, counseling, or support. Some of the companies are now trying to add that in so that you can call a hotline, or you can have an app that you send a message to if you need this kind of support. But a lot of the over-the-counter hearing aids don't offer that. These are just an example of 3 hearing aids that are very high quality that we often do recommend if people go down this route. So Jabra Enhance, which is a behind the ear type of hearing aid, runs from about $1,500 to $2,000. The Eargo 6, which is completely inside the ear, that's $2,500. And then the Jabra Enhance Plus, these look like earbuds. So they might be a little bit more obvious than the other 2. These go for about $800. And if you go for an over-the-counter hearing aid, we still, again, recommend that you see an audiologist, get a real hearing test, and get an audiogram. An audiogram is very similar to a glasses prescription. So a glasses prescription tells you what your visual acuity is and what your eye's magnification needs are. An audiogram is how we can tell what your hearing level is and how we can actually customize the amplification of your hearing device to your hearing. It's also still recommended that you see a doctor just for a checkup to make sure you don't have any medical conditions causing the hearing loss that are reversible. So middle ear conduction problems like otosclerosis, tumors, or infections. So it is recommended you just get fully checked before you make a decision about over-the-counter hearing aids. And so then how do you decide between over-the-counter versus prescription hearing aids? The first thing is the severity of hearing loss. Over-the-counter hearing aids are made for people with mild to moderate hearing loss. If you fall into this range, that means you're asking people to repeat themselves frequently. You have a hard time hearing very soft voices. You might be turning up the TV, you might have some trouble in background noise. If people are outside of this range, meaning their hearing loss is more severe, then often those are people who they're asking people to speak up in order to actually understand them. And then over-the-counter hearing aids are only able to provide adequate amplification for mild to moderate hearing loss. And this is mostly a safety measure. It's to prevent people from over-amplifying themselves and causing additional noise-induced damage to their hearing because they're turning up the device really high for severe hearing loss. Think about how much help do you actually need? How much support do you need? So over-the-counter devices have a wide range of assistance in fitting and troubleshooting. Low-level assistants are devices from SoundWorld or Autophone. There's no professional providing assistance. Mid-level assistants are from Sony, Jabra, and Lively, where you can get an audiologist or hearing professional on the phone. And then prescription hearing aids, you have full support from an audiologist, and included in the cost of the hearing aid is often the support the support appointments that you need. A lot of the follow-up appointments that you need with the audiologist can be billed to insurance. So you might be paying for the device, but the visits to the audiologist are billed to insurance. The other thing to think about is how much fine tuning that you want. So over-the-counter hearing aids have lots of presets, which basically means you just kind of go with what works for most people. Some people want a little bit more control, so they want to have some self-fitting. So there are some over-the-counter hearing aids where you can actually make the adjustments to each individual frequency yourself. And then prescription hearing aids have the highest level of fine-tuning and adjustment, where the audiologist takes every single frequency and makes sure that the hearing aid is only amplifying what you need and not over-amplifying. The audiologist also verifies the hearing level by putting a microphone in your ear canal. I will say we just don't know a lot about over-the-counter hearing aids. So there are some studies that are going on to try to show the efficacy and try to actually see if patients are able to fit hearing aids themselves to get good enough benefit, and then how they work in background noise. But I'm sure a lot of that information will be forthcoming in the next few years. I also think about, what do you look for in prescription hearing aids? So something to keep in mind is that there are facilities that offer free hearing tests. Those facilities they're not really free. It means the test is being performed often not by an audiologist. And often, I think the real downside is that they only carry one manufacturer, and you can often only go to that place to have your device programmed. You can't really go to another facility. So if you go to a place with free hearing tests and consider one of their prescription hearing aids, really try to find out, do they have a wide range of manufacturers? And then if you were to move or you were to go to another facility or another audiologist, would they be able to help program? So I recommend seeing either a private practice audiologist, a hospital setting, or Costco. And Costco is a great place to get hearing aids. When you go there, just request to be tested by an audiologist. And at the hearing aid evaluation, ask if they do real ear verification. That's where they put the microphone in your ear canal. They make sure that you're getting the right hearing level. You're not going to damage your hearing. And that's the gold standard of hearing aid programming. Other things to think about. So the HLAA did a survey to all of their members and asked, what do you look for in your hearing aids? So generous trial period is really important. The state of Maryland is actually mandated by law. So long enough that you can actually try the hearing aid in your home environment, make sure it actually works for you. A customizable sound, so you can adjust the hearing aid for the setting that you're in. Multiple sound environment settings. So if you're in a lecture hall or in your busy restaurant, if you're alone at home, that you have different settings that are appropriate for those things. That also includes customizable microphones, so that you can, if you're in a setting that has a lot of background noise, you can actually hear the person across from you. You can point the microphone to that person and block out the noise that's coming from behind you and from the sides. And then a lot of people look for Bluetooth compatibility, so they can connect their hearing aids to their phone, their TV, their laptop. There are a lot of different styles of hearing aids. So at a hearing aid fitting, you're going to fit your hearing frequencies to amplify only what you need, and you also physically fit the device on your ear. Features that you'll go through when you're looking at the different types of hearing aids are, number one, the directional microphone. So to see if you can hear somebody directly across from you. Noise reduction to reduce background noise. Feedback suppression to prevent that squealing sound that hearing aids often used to have. There's something called a T-switch or a telephone switch, which allows you to switch from a normal microphone to a coil that can actually help you hear on a wired telephone. And then I know most people don't have wired telephones as much anymore. So wireless connectivity is becoming increasingly important. So you can hear streamed audio from your phones, hear music, and then direct audio input, where you can actually plug in your hearing aid to a remote microphone or an FM listening device, which is usually more relevant in kids who are in schools. Cost for prescription hearing aids ranges about $2,000 to $6,000 for a pair of hearing aids. I do not push high-end devices. None of my audiologists do either. We always check insurance benefits and try to get you the maximum coverage. And then for people who are cost conscious, honestly, Costco is a great place to go for hearing aids. They have great quality devices that are much more reasonable in price, but still about $2,000. Hearing aids are expected to last about 3 to 5 years. If you have insurance coverage, that usually allows you to buy a new set every 3 years or every 5 years. And then finally, let's talk a little bit about severe to profound hearing loss and what your options are at that point. So I think this is something that most people don't know a lot about, but we have a high number of people with profound hearing loss that are actually candidates for something called a cochlear implant. And this works completely differently from hearing aids. So hearing aids amplify sound and really just act as microphones to amplify the sound. Cochlear implants actually bypass the damaged part of the ear and directly stimulate the auditory nerve. And cochlear implants are really the only way of restoring your lost hearing. The signal that's generated by the implant is sent directly to the auditory nerve, to the brain, and then the brain recognizes that signal as sound. Criteria are actually wider than I think most people realize. So for candidacy for cochlear implants, you have to understand less than 40% of words in the ear that's to be implanted. And then the opposite ear has to understand less than 60% of words. And those are the criteria for Medicare. We found that there's a big healthcare access issue. I think it's just that there's very little awareness amongst even physicians and audiologists that their patients might be candidates for cochlear implants. So only 4% of people who have hearing that would qualify them for cochlear implants actually end up getting a cochlear implant. And that's mostly because they never hear about it as an option. There is a lot of fear of surgery as well, which I fully understand. I will say it's probably my favorite surgery to do. It's very straightforward. It is an in and out procedure. You go home the same day, and it's become really standard of care. So it doesn't require a long stay in the hospital. It doesn't require a big incision. It's no longer an experimental therapy, and it really has not been since the 1990s. So we've been implanting people for about 35 to 40 years. And at least the last 20 years, it's become a standard treatment for people with severe to profound hearing loss. The way that they work, there is an external device that you wear on your skin. So there's a microphone that goes on your ear, and then there's a little coil that attaches magnetically to the internal device that's under your skin, and that transmits the sound to the device. A lot of the newer devices don't even have this big part that goes on your ear. All it has is everything on a little coil. So there's just the coil at the top of your head. The internal device has the body of the device, which converts the sound into an electrical signal, and then it goes into an electrode array that is directly implanted inside the cochlea, which stimulates the hearing nerve. So once again, there's a sound processor that sits on your ear. More modern ones, they're actually incorporated into the part that's in the magnet that captures the sound, turns it into a digital code, and that also has a battery that powers the whole system. The sound processor transmits that code to the coil, which magnetically transfers it to the implant that's under the skin. And then that goes into the cochlea. The implant converts that sound to an electrical signal in the cochlea. The electrodes stimulate the hearing nerve, and then that stimulation goes to the brain. So here are your key takeaways, and hopefully I think there's perfect amount of time for questions here. So number one, hearing loss is very prevalent. So 2/3 of people over age 70 have hearing loss, and that is significant enough to interfere with their functioning. Hearing loss is linked to dementia, and it's very insidious. We're often not aware of our own hearing loss because of how well our brain compensates. And so we're often withdrawing from situations or learning to tune things out and not aware of how severe the hearing loss has been. I recommend everyone get a screening at age 65 and then rescreen every 1 to 2 years. If you get hearing aids, there is an adjustment period for your brain to relearn how to interpret sound. And then the earlier you get hearing aids in the course of your hearing loss, the less your brain has to relearn and the faster you adjust to it. If you get over-the-counter hearing aids, they're good for mild to moderate hearing loss only. They're not meant for severe or profound hearing loss. Prescription hearing aids are for all types of hearing loss. And then severe to profound hearing loss patients might actually be candidates for cochlear implants. So if you're not hearing about that and you have severe to profound hearing loss, ask if you could be a candidate or if you could get tested for it. All right, and then there's my contact information again, and my email if you have questions. I would be happy to answer some more questions.
Thank you, Dr. Galea. That was a wealth of information and really appreciated it. So we do have some questions. Our first question is there a, it was asked during at one point of the presentation, but is there a difference between hearing loss in one ear and hearing loss in both ears? That's
a great question. So I'm talking about hearing loss that happens in both ears symmetrically. And so our ears are exposed to same genetics, same environment, same age. So we expect both of our ears to have the same level of hearing. If you have an asymmetry where one ear is worse than the other, that is an indication that you do need to see a doctor or an otolaryngologist, because we have to make sure that it's not because of some anatomic problem in that one ear that's worse. And so it is not typical to have one ear worse than the other, but if you do have that, it would be a reason to see a doctor.
Great, thank you. Can a behind the ear hearing aid be used if you also wear glasses?
That's a great question. Great question. So especially in the last few years, I have patients come in, they have behind the ear hearing aids, they have a mask on, they have glasses. It's a lot of stuff to be sitting on your ear. People do successfully use them if they wear glasses. I think often the ones that have a very, very small wire tend to work pretty well. But they have the in the ear ones also. So if you wear glasses, you can try the in the ear hearing aids, and that can also be a good option for you.
Thank you. I know you touched on this, but do hearing aids still emit a high-pitched squeak when being adjusted, like they used to?
So not nearly as much as they did before. So they have, most of them have a program now to try to suppress that. It's really not as much of an issue as it was before.
Thank you. And where can you find a reputable private practice to go to for hearing aids? Are they rated anywhere?
Yeah, that's a great question. I mean, I think this is one of the issues in healthcare overall, is you don't really know if the person that you're seeing, how reputable they are all across healthcare. So I would look for the audiologist, making sure that they're credentialed, that you actually have an audiologist who's testing your hearing, and then ask them, what types of hearing aids that they actually sell. Make sure it's a wide range across multiple companies. Most otolaryngology practices that have an audiologist working with them will have a highly reputable audiologist working with them.
Thank you. Okay, and again, everyone, just as a reminder, you can put your questions in the Q&A box at the bottom of your screen. Okay, and let's see. So you said you recommend getting, your hearing checked at age 65. What are, the most important factors to look for before the age of 65? Mm-hmm. That would mean you should go to the doctor.
So if you start to notice new onset tinnitus, that would be a reason to get your hearing checked. Tinnitus is actually a side effect of hearing loss. So we often say that it's akin to phantom limb syndrome. So if you lose a limb, you're going to feel, your brain will make these signals like you still have pain or itching or some sensation in that limb that's lost, even though there's nothing generating that sensation. The same thing happens with your hearing. So if you lose hearing, your brain starts making this phantom sound And that's what tinnitus is. So if you have tinnitus, it's a good idea to get your hearing checked. Other things to look for is if you have a sudden drop in your hearing, that would be another reason to really urgently get your hearing checked. Make sure it's not just wax in the ear. There is something called idiopathic sensory neural hearing loss, where you can suddenly completely lose hearing in one ear, where if we treat that right away, we can actually restore your hearing.
Oh, thank you. And let's see. So if you have some hearing loss in one ear and it is stable and being tested yearly, and you have seen a doctor yearly, should you still get a hearing aid or should you wait?
I think it depends on the severity of your hearing loss. So, if you have mild hearing loss, no one's going to say that you have to get a hearing aid at any level, especially because of the insurance coverage situation and what it is right now. But if you have mild hearing loss, you can probably get by without a hearing aid. If you have moderate hearing loss, even though it's stable, I think it's because of the link to dementia and the link to social isolation. Even if it's not getting worse, it's probably a good idea to get a hearing aid to prevent some of those downstream effects.
Thank you. And so you mentioned hearing loss and dementia, but they, but not why they would be causative. Are they just correlated?
Yeah, that's a great question. So I have not been personally involved in a lot of the research at the School of Public Health or in the animal models. They've done several research studies in animal models. They have found a causative effect by controlling for multiple comorbidities and then prospectively studying patients as well in a long prospective study called the Baltimore Longitudinal Study of Aging. I can get some of those references, and if you email me, I'd be happy to send them over. But I think in the literature, it's been settled that it's less likely to be correlative and more likely to be causative.
Thank you. So is one style of hearing aids better than another for someone with moderately severe hearing loss? Example, in the ear or over the ear?
That's also a great question. So there's really no difference in those different styles of hearing loss. That's more a personal preference kind of thing. So if you're wearing glasses, you want something in the ear, that's reasonable. Most people like the over the ear type because the dome ends up being something open. So when they put the plug inside the ear, it doesn't feel like their ear is plugged, whereas in the ear type, it can feel like your ear is plugged. So I recommend trying a couple of different types and seeing what you like the best, but it's not like one type is best for severity of hearing loss.
Thank you. So, when this person was younger in the late 1950s and 60s, they had many ear infections, once had both ears and throat abscessed at once. Their hearing was pretty normal until their late 40s, but could that all have impacted their hearing?
Yeah, absolutely. It definitely could have impacted your hearing. And I will say, as the physician, these are the patients I often see, the patients who have had long history of ear infections, because you might have something reversible in your hearing loss. If you have scar tissue in your middle ear, that could be something that we could actually address, but it can absolutely impact hearing.
Thank you. So, the 3 to 5 year figure was surprising of the hearing aid. Is there any way to make that time frame longer for effectiveness of hearing aids given the high cost?
That's another great question. So I do have patients that keep their hearing aids for up to 10 years. And I think that's great if they work for you. Continue to use them for as long as they work. I think the reason that most companies are saying 3 to 5 years is because of how quickly the technology is improving. And so I do have a lot of patients saying, I got my hearing aids 10 years ago. They're just sitting in a drawer. They don't really find them that useful. They might be surprised at the quality of hearing aids today compared to 10 years ago. I think you can probably make them last longer. There is also that service that is attached to the hearing aid if they need to be replaced. I think some hearing aids, when you buy them, a lot of the service for replacement, basically like a warranty, is limited at 3 to 5 years.
Thank you. How can a perforated eardrum affect your hearing?
So that will reduce your hearing if you have a perforated eardrum because your eardrum is not vibrating. And so you've lost a lot of that vibration mechanism to convert the sound energy to an electrical signal. That's something we can fix, and that is a fixable cause of hearing loss.
That's great. Thank you. Is the NIH doing any hearing studies?
Yes, very, very, very many. So the NIDCD is the institute at the NIH that is basically entirely committed to diseases of hearing and communication. So many of the studies they're doing at that NIDCD are about hearing loss.
Right. And do you always get hearing aids for both ears?
You do if you have the same level of hearing loss in both ears. So yes, most people do get hearing aids for both ears. If you have an asymmetric hearing loss where the hearing loss is only in one ear, again, that's a reason that you would have to see a doctor. But those patients might only get a hearing aid in one ear. And then I also have patients that are completely deaf in one ear and have some hearing loss in the other ear. They choose not to wear a hearing aid in the ear that's completely deaf.
Thank you. I apologize in advance for my pronunciation for this question. So before COVID, this person had severe otitis media, so had to have their
Laryngotomy.
yeah, thank you, in both ears. Right eardrum was successfully repaired, but repair of left ear failed. The perforation came back. And the ENT says if tympanoplasty is redone, it would not improve hearing that much. Would this be a good candidate for cochlear implant?
That's another good question. I think it would depend on the severity of your hearing loss. So we'd still have to do testing to see how poor your hearing loss is. Because the cochlear implant is an implanted device, we wouldn't want there to be any communication between the device and the outside world so that you don't get any infection. So even if the tympanoplasty would not improve hearing that much, we'd still want to make sure there's no hole so that if you get an implant, that hole is not a conduit for bacteria to infect the implant.
Okay, thank you. So, and what is the cost of cochlear implants?
Yeah, that's a great question. So cochlear implants are covered by insurance. The cost to the patient is basically whatever your deductible or copay would be for your insurance. The device costs about $25,000. Patients do not pay $25,000. It's like getting a knee replacement or a hip replacement. You're not paying for the device. That's part of the surgery. And this is, I think, this is a little bit more editorializing about the healthcare system, but it is a little odd to me that insurance companies will almost fully cover a cochlear implant, but will not cover a hearing aid. And that's often a theme that comes up in other places in healthcare as well.
Thank you. And how big is that device, the cochlear implant?
That's a good question. It's let's see. It's probably about 3 centimeters long and about 2 centimeters wide. So that's the device that goes under the skin. The thing that goes on top of the skin is about the size of the top of my water bottle container. So maybe 2.5 centimeters across in diameter.
Great. Well, thank you so much, Dr. Galea. You have so much valuable information. And thank you for being here. Thank you everyone for joining today. And again, Dr. Galea has shared her contact information, and I will be sending out the recording and the slides shortly as well. So have a great rest of your afternoon, and thank you, everyone.
Thank you so much.